Hi everyone, welcome to PACES Blueprint channel. In this video, we will go through the basics of cardiovascular system examination for MRCP PACES in a clear, structured and examiner-friendly format. By the end, you will know exactly how to perform and present a perfect CVS examination in a PACES exam. We will get 10 minutes for a station. In a 10 minutes, we have to finish the examination within 6 minutes. So how to perform a CVS examination within 6 minutes? There is no alternative way. You have to practice as much as possible. Then starts with the hand rub and introduce yourself with your name and your designation and get a consent from the patient and confirm the patient's ID with their name and age and make a position of 45 degree of a patient for a CVS examination and expose the chest for the examination with the patient consent. Then take a step back, observe the patient from the end of the bed, look for any signs of distress. What I mean by distress is look signs for dyspnea, cyanosis, sweating, anything, or patient in pain. Then look around the bed such as O2 mask or a temporary pacemaker or NTG inhalers. If any is present, you have to mention to the examiner. Then move to hands. Firstly check for infective endocarditis signs. You have to present every case in CVS with the starting of infective endocarditis signs such as splinter hemorrhage, look at the nail bed, then Janway lesion, then Osler's nodule. You have to comment that if there is a infective endocarditis sign. Then check for clubbing, cyanosis, PLR. Then check for sweating. If the patient is hyperthyroid, then there will be a sweating and you should actively check for atrial fibrillation. Then check for long fingers. Arachnodactyly for Marfan syndrome. Then if it is present, then actively check for AR murmur or MVP murmur. Then go to pulse. Initially start palpating both hands to check radio delay. Then check heart rate. Then if it is regular or irregular, then comment on its volume and characters. Then palpate brachial artery. You have to comment the volume of the pulse in brachial artery or carotid. While palpating the brachial artery, you should use your right thumb to palpate the right brachial and left thumb to palpate the left brachial. Then after this, you have to check blood pressure. You won't actually measure the blood pressure, but you will ask the examiner too, I would like to know the blood pressure. If the examiner tells the blood pressure, then it gives a clue to your diagnosis. If there is a white blood pressure, then it gives us a AR, sign of AR. If the blood pressure is narrow, then it is a sign in aortic stenosis. Then after finishing the blood pressure, go for in phase. Phase, you have to see signs of mitral phases or any amiodaron induced Slade-Grave phases or signs of Down syndrome, where Down syndrome is more associated with VSD and ASD. Check for any elastic skin in Ehlers-Danlos syndrome, which is associated in AR. Then proptosis for thyrotoxicosis, which is associated with AF. Then as usual, a general pallor, icterus and cyanosis. In every valvular case you are going to present as a diagnosis, you have to comment on pallor and icterus. That is a complication of the valve replacement, where pallor is due to the hemolysis in the valve and the icterus is the consequence of the hemolysis. And after the phases, comment about JVP. I forgot to tell one. In pulses, you have to check for collapsing pulse. Make sure patient has no pain during the procedure. So previously ask the patient whether you have a pain on your joints anywhere. If patient tells pain, don't perform it. Collapsing pulse is present in aortic regurgitation. Then go on JVP. Tell whether JVP is elevated or not. That's enough. Don't need to comment on the JVP waves. It is more difficult to tell. JVP elevation or not elevated is enough in the examination. If JVP is not elevated, then ask the patient whether he has any tummy pain or not. If he or she tells no, then perform hepatojugular reflexes. Hepatojugular reflex is a sign of right heart failure. After JVP, go to precordium. In precordium, first inspect for any chest abnormality. Then scars. Scar is a main finding in the PACES examination. You have to find the scar if it is. Check carefully. There may be a mid-sternotomy scar or lateral mitral-valvulotomy scar. You have to check carefully for the scar. Then any visible pulses and inspect for apex beat. After inspection, go for palpation. Palpate for loud P2, any palpable thrill, heave. Then confirm the apex beat by palpation. Comment whether the apex beat is displaced or undisplaced. Then auscultation. Auscult all the areas like aortic, tricuspid, pulmonary and mitral area with diaphragm and make the patient in left lateral position. Auscultate the mitral area with bell especially for MS murmur. Then ask the patient to sit forward and auscultate aortic area with diaphragm for AR murmur and auscultate the carotids with bell for aortic stenosis radiating murmurs. Remember that all the right heart murmur will increases in inspiration. All the left heart murmur will increases with expiration. The mnemonic is RILE. Then for HOCM and MVP alone, these are the two conditions where when you are doing a dynamic auscultation, the murmur intensities will be increased. Where the all other condition, on dynamic auscultation, the murmur intensity will decreases. So after doing this, go for a auscultate the lung fields for looking for bibasal crackles. Then check for sacral edema. Then check for pedal edema and peripheral pulses, and end the examination by thanking the patient. Now you have to summarize the case to the examiner. Mention infective endocarditis, then tell about the pulse, rate, rhythm, then BP, then tell about JVP, then tell about precordial scars, then tell about apex beat, then tell about S1, S2, S3, S4, and lastly mention the murmur with, and finally end the presentation with diagnosis. In next session, we will see how to summarize the case in very short and crisp manner. Thank you for watching the video.